Good evening, everyone. First of all, let me thank the Maldivian Nursing Association and the president for inviting me. I think we met about a month ago, month and a half ago, and that's how the whole conversation started. And I really appreciate the enthusiasm that's shown by you and your colleague in uplifting nursing care in Maldives. And I think in Sri Lanka, we have done a lot, and especially I would love to support nurses for the last 17 years, creating a professionalism in nursing and upliftment of the nurses to the level that we have achieved today in Sri Lanka. So let me just to give you a brief on basically what risk management is, and then how you can start a small risk management program in your unit, and then what are the challenges. Just due to the time, we could only just give an introduction. Hopefully, one day we should be able to do a nice workshop and then create some real stuff with you. Let me share my presentation. Um, can you see my presentation?
Yes, sir.
Yes,
Yeah,
it's visible.
lovely. Um, yeah, it's about healthcare services risk management. I just wanted to give you an overall view, just to create some concepts in your head before you look into a more deeper length of risk management. It's if you look at the so I'll talk about the risk management and the processes of risk management, and of course the way forward. If I ask a question from you, this is a very old slide. I have been keeping, because I have been doing this for ages. Um, this I used to show it to everyone. This is there are about 5 hospitals in US, Australia, and Denmark. If you look at this hospital, what is the best hospital that you can say out of looking at? There's a percentage of adverse effects. If you get sick, which hospital that you will go to? Anyone?
I think I'll go to Australia.
You go to Australia. Okay.
Yeah.
Anyone else? It's an excellent answer, because most of the time hospitals they underreport. The hospital that report most is the one of the best hospitals. So if you look at even our hospitals, there's zero adverse effects because they are not reporting. That's a very dangerous scenario, because if you look at the current trend in the world, what we do in hospitals, and that our human body is a wonderful body, unique uh, thing that consists of systems, and then these systems are mostly get imbalanced with the different effects. Then we have to rebalance these systems, no? Let's say cardiac output is not there, we'll have to improve the cardiac output. The urine output is not there. You do that, either input, output, and then you balance the body. That's why we are doing in our hospitals, like just like the mechanic who's balancing the vehicles. When there's a petrol block, they would organize that, remove it. But our one is much different to what they are doing. But at the end of the day, why we go into body systems and we do interventions, and we do intervention with a view to again rebalance the system. So in nutshell, that's what we do in our hospital. So we do different types of interventions, where maybe physical interventions, we surgically remove things, or we do chemical interventions, we do medicines, or mental or psychological interventions, or social or behavioral adaptation. So that's what basically what we do. But the issue is not easy, like the mechanic would repair our vehicle. It's beyond that. Now, um, the classic example is that this one, if you sending a rocket to the moon, this is the example I use for ages. If you send a rocket to the moon, it will take exactly major four risks you can identify, where the the rocket, uh, the dispatch from the Earth, the initial lift of the rocket, and it goes out of the Earth and then lands on the moon. It's generally a minimal risk because zero gravity. Again, coming down into the Earth and then landing on the Earth. So there are four very easily identifiable major risks. Now tell me, when a person comes to the hospital, until he is discharged, how can you identify the amount of risk that they go through? It's very difficult. The classic example, as nurses, that they would ask first thing that they come to the hospital, once they are settled down, the first thing that they would ask from you, Miss, when can I go home? So you immediately say, yes, yes, you can go home tomorrow. You won't say that. You won't say that. You would tell them, okay, we'll see. You never give a proper answer because you can't give an answer because you in that moment you know how many risks are there in the hospital sector. There are risks from the environment that you do interventions. There are risks from the people who are doing human errors, and there are drugs that we use, supplies that might not work or give adverse reaction, or the equipment can create something, or somebody has used a different methodology. So likewise, there are different massive risk levels that you have. So therefore, healthcare is not a very predictable service. So other services, if you go to a hotel, you know exactly you can have fun or have meals, and there are predictable outcomes in the services. But healthcare, you can't predict what's going to happen. If you tell this to patients, nobody would come to our hospitals. But we won't tell them. But we know the risks. So interventions are extremely risky, and it's our duty to look after the patients. Now, there are currently, we have put some controls in the healthcare to mitigate these risks system-wise. System-wise, we have put some mitigation, all the prevention methods. One is the healthcare services is a regulated industry. Nobody just can start starting a hotel. You can't just start. You have to go through several approvals. So by law, it has been there's this healthcare legislation, healthcare laws are there. So under that only everything happens. And even if you get through a degree, people who are working, degree or a diploma won't allow you to go and practice. There's another professional body who would look into you and say whether, okay, you're good, you're bad. There are nursing boards, you will give a license to practice. They give a license to practice to do good, not to kill anyone. So it's a different license together. This is the only license given to do good for people. Other license can do bad all the time. So this is a different license. And then every healthcare intervention, if you are doing any kind of an intervention, that has to be a recognized place called hospital or healthcare center. That by law it is given. So under that also there are regulatory activities that you do. We have policies, we have protocols, we have different control mechanism within the hospital, healthcare center to safeguard the patient. Then when you try to do a procedure, intervention, each intervention has a protocol. Each intervention is also taught thoroughly, especially nursing and the other medical professions have been taught, this is the way to do. This is the way to do. There's no other way. Only one way to do. If there's a deviation, this is what you do. So everything is very systematized. So there's a lot of control in this. We have put a lot of controls in this. And then there's another thing, which you're dealing with not with a car. You're not repairing a car. You're not repairing a computer. You're not dealing with this is a life. You're the live person. talking, walking person that you are dealing with. So there are things that we have to be careful with when you try to do interventions. So in simple sense, you can't harm a person, but you have to do always good. Without harming, you can't do intervention also. For example, you can't give an injection without pain. Pain is a must. I mean, it is there. I mean, otherwise you have to be very senseless to not to have pain. So you will always have pain. So how can you control this? So okay, now there is no pain. Ah, no, I can give any amount of pain when I give injection. Can I do that? No, we can't, because it has to be controlled. Now the ethics will control. There's this gray area, not black or white. This gray area is controlled by ethics. So that is also there's a control mechanism. Now, other than the general risks in healthcare, Maldives has enormous amount of risks that you don't see it in surface. What are the problems? Geographical challenges. You have vast majority of islands and spread across, and then remote islands. And you have to refer patients because these different islands have only limited services and limited healthcare professionals. And then you have a fair amount of expatriate staff, coming from different countries. Their training is diverse, different ways, and their orientation to your system, your people, could be different. And resource constraints, of course, lack of equipments, lack of sterilization procedures in different places, and you are living in a tropical country like Sri Lanka. So you are bound to have so many things that are not seen in other countries. So extra, because of the heat, there's a growth in certain bacteria, and there are certain diseases, certain vectors. And waste management is actually a problem because you can't just throw everything into the sea, and you have a limited land mass, biomedical waste, etc. It's enormous amount of problems. And then the other thing is transportation because of the distance for you to refer into a high-end facility. There are evacuation delays. Weather is a major thing from A to B. Now, if in Sri Lanka you go into a road, you walk onto one A to B. But you have to move from one island to another. It's a different adventure altogether. When you look at the healthcare risk management, we have to really understand. We have to understand what the risk is, what these names would envisage. Risk is basically a probability to have a harm or injury, right? So there are different names: hazards, health risks, adverse events, near misses. All these have to be. We have to know what these are, right? Near miss is you have done something, but there's no you used the wrong drug, but there's no injury, so it's a near miss. Or you tried to do something just there, but nothing happened. You didn't do it. We was about to do that. A near miss. And adverse reactions is definitely once you do a procedure, there is a injury. It could be a minor to major. Hazard is a major injury, right? Our goal is to reduce harm, improve care, improve efficiency of the system, and the protects not only the patients but also staff. Let's look at the risk definitions. Risk is a possibility of harm, loss, or adverse outcome during a uncertainty. As I told you before, we know that there's uncertainty. You can't predict healthcare services. And then there's chance, as I told you before, can injury can happen to the patient, staff, and then when it happens to an organization, staff and the unit, the whole organization is at fault. It may be detrimental to your image, right? So it can be medical errors, can be infections, equipment failures, or maybe unsafe practices done by a couple of staff members. So therefore, we are looking at mostly what's the probability of the risk and what is the impact of the risk. I'll talk to you in a while. Risk management is we are managing this unpredictability to a predictable, somewhat predictable status. And then if it's something going to happen, we should be able to identify. That's what the basic underlining cause of risk management. So identify, assess, then reduce and monitor continuously, and then you go into a major another risk and then try to control every day. Um, yeah. So once you do the risk management, it's not only managing the risk by avoiding or mitigating risk, but this is a good lesson for us to look at prevent errors, train staff, opportunity for trained staff, ensuring compliance, your compliance into your adherence to different quality systems and safety standards. Um, Patient safety itself is an important area. I think it's your patient safety week. Very important to work on this. I really value your approach to patient safety in a kind of a very frugal areas that you all are working in. So therefore, it's good to have this discussion going forward. So patient safety, prevention of errors and adverse effects in patient associated in healthcare. So we will try to remove the harm and try to do good as much as possible. So not only creating a system, but also creating a culture of safety. Now, for example, I mean, sometimes I have seen in Sri Lanka as well. Um, so somebody does something wrong, and the nurse would ask, "So what? So why? I mean, so what?" It's like it's okay to do that something. It's not that because if you do a minor one, it could be a major in years to come. So therefore, it's important to do. There will be zero errors. That should be the standard that we should make sure. And then you have to encourage reporting errors. That's the very most important thing. Allow creating a culture for people to influence and then come out and say, this had happened. Okay, let's look at whether it's a human error or a system error, and let's sort it out, as it is. Um, that's patient safety, the fundamental principle of a patient care and a quality management as well. Now we can talk about quality without looking at the patient safety. There's no quality in the system. You can have a beautiful hospital, beautiful people walking, but if you have not attended to the basic safety procedures, then there's going to be it's a time bomb that can blow at any time. Um, yeah. So basically, the main complementary actions is to prevent adverse errors and making them visible and mitigate their effect. Prevent the adverse effects as much as possible. I know you can't. You are not a god to stop all this because we are human beings. We are working in a very difficult areas. You can make an error. That's okay. I would say it's okay. Is that make it visible and try to identify what went wrong and study, train the staff, so prevent that happening again. The making them visible is very important, and then of course then take action or mitigating or preventive action to stop that. Um, when you look at the healthcare services risk, we always look at the clinical risks. We all the time, I'll risk that as I mean, I was a ex CEO of a larger health group in Sri Lanka, Hemas Group. I was the CEO sometime, and then I was a medical administrator. For us, it's not only clinical. As in charge of the organization, it's not only clinical, not only medical errors. We also look at the operational risk as well. Staffing, lack of staff, equipment, supply chain. If we don't have that, these operational effects will definitely go down to clinicals. Clinical services are the core area, but all the operational parts is important to work with you. Otherwise, you are going to have a medical error. So environmental risk, waste management, facility management, that directly uh, directly related to infection control, and then aligning with the legal and regulatory standards. Because, and then there's liability. If you don't, there's a chance of suing, litigation by the patients, and it's and safeguarding documents, etc. Human resource risks, because patient staff can burn out, especially the nurses, and I mean training can be hampered, and then there's communication failures. All that there are risks that would really affect the healthcare services, because you have to understand you might have AI and all the new technologies coming in, but without human hands, especially the nurse's hand, you can't run healthcare. You have to have, you can't duplicate, you can't substitute the nursing care, especially nursing and medical care, especially nursing care. So nobody can replace those hands. And then when you look at the financial risk, when you have we have to really look at that as well. So if you have a litigation case, you might have to pay penalties. And then if you have a adverse effects, you might keep the patient for more than what you expected. Then what happens is then there's a cost for it, a patient as well as the hospital. And the other thing is technological risk. Now it's very risky because most of the hospitals, we love to have these computerized systems, etc. But you have to understand, those days we used to write everything in manual. It was difficult to write, but it was very safe. No, nobody can come and hack it or remove it. But now the thing is, there may be if you don't have a proper system, overnight the whole data breaches can happen. So there can be software failure, very common to happen. We can't have a software failure and keep the patient at risk. So those are some of the other things that you might have to really look at if you are running an organization. If you are the in charge of a unit, you might have to look at the others as well. Otherwise, we'll be looking at a tunnel vision, only looking at the clinical ones, which the other surrounding risk can affect you directly. So when you really look at the risk, of course, you don't expect this to happen, and it happens, right? But you have to understand what is that risk is, what can happen. So there are people do reactive methods. They just suddenly do reactive methods when there's an incident, like accident investigation, do root cause analysis, and then you report. Or then proactive methods, before it happens, you look at areas that could have a risk, and then you look at near misses and safety concerns, or that's called prospective risk assessment. For the future, you do a risk analysis. There's a retrospective one called reactive methods. You go look at the past ones, and then you look at immediately do investigation and come up with a plan to stop that risk happening again. Or you can simulate, looking at the area, you can create a prospective risk analysis. Now, key areas in clinical risk analysis is you look at the infection control, you look at the safe use of medicines, equipment safety, safe environment, and safe clinical practice. Those are the clinical WHO looks at mainly these 5 areas. It's good to start with these 5 areas rather than trying to do everything, and then you can move towards others. How can you do a risk analysis? There are different types of risk management methods are there. So I have put it up there just for the sake of knowing that there are different types. One is the root cause analysis, RCS, failure mode and effect analysis. There's another system. Checklists and SOPs, standard operating practices, audits and feedbacks, key performance indicators, simulations and drills. So different types of risk management methodologies are there. There may be a combination of many. It could be one, and you can start there somewhere. So how can you start a risk management, healthcare services risk management? If you want to do it in a small unit, it's nice to identify. Um, First, look at the previous issues. Audits, have they identified? anything or incident reports. Those are very important for us to identify the more prioritized areas to start on risk management. Then you assess, you validate the risk likelihood or the severity of prioritization. I will come to that in more detail in a while. Then you put control systems, protocol, checklists, then training and policies. And then they monitor. Once you do that, you just monitor and continuous reviews had to be done and then improvement. Then you start reporting. Uh, but these are non-punitive. You can't punish people for this. You can, and near miss learning. This is not a fault finding exercise. Minute you start finding fault, people will not come out. Then it will put under the carpet. Then it's a big bomb can create one day. Huge issue can happen. So it's very important to create that culture, not fault finding, but fact finding, and try to mitigate the risk rather than try to focus on the person. It's nice to focus on the system. Typically, when you look at an organization, you select a department in an order of importance. Now, when you look at the when you look at an organization, you can see more the high risk areas are there, no? High dependency areas are there. Then there is a moderate path, and there are mild ones. So you identify the department first, whatever the department is, and then you have to conduct a thing called a process analysis. How let's say if you take a let's say if you take a ward, patient would come into the ward, input at the registration is one key point, right? And then they would you allocate a bed, then you do the investigations. Then the examination is done by the doctor, and then you do your assessment, and then the investigations are done. Then the intervention is done. Then you monitor and keep the patient, and then you discharge. So that's if you look at the process. In that process, go into more details and see registration. For example, if you have the wrong name, you might uh, get the wrong patient for surgery. If you have the wrong diagnosis written somewhere, if you don't validate, if you don't look at the past medical records and then look at allergy or drug reaction, then you can have that another one. So therefore, it's very important to look at the processes, registration, bed allocation, know your assessment, and then investigation, treatment, and then discharge. So under that, you'll have to go into details and see what is happening there. It's called a process analysis, right? You identify the processes, key functions in that area, and probably key activities, and see well, what can there be a can there be a risk in this. But looking at the past records and past investigations, case studies, or complaint, it's good to look at they you know which areas are more vulnerable for risks, and then identify the risk areas. You find the department, do a process analysis, and the risk areas, and pick up some of the risks. Now I'm going to show you some very old, about 20 years old document, but it's still, I think it's still good, which I was part of this particular uh, uh, policy making in a Malaysian, American Malaysian hospital. Now, nursing care. Now, these are the things that they identify at that time. Now, things have been different. Unable to deliver quality nursing care due to staff incompetencies because there were untrained staff, there were few staff, they were not properly clinically oriented in Malaysia. Excuse me. Unable to deliver quality nursing care through inadequate staff. That's a common thing. No? One thing can be lack of training. Second one, the who can't give a quality care because not enough staff members. In the existing staff members are burnout. They work for a couple of shifts and it's difficult for them. Unable to provide specialized nursing care because now you have general nurses a lot. Lack of specialized nurses are there. We Sri Lanka they identified this and we started about 10 specialization because of that. because they have general nurses going there. To training takes a while for them. They go with empty-handed. But if you have a trained staff for ICU or whatever, then it's easier to emerge and then you can do a hands-on training. Incorrect charging of consumables. Sometimes people charge more or less for consumables that you use. Everything is the cost in healthcare. Inaccurate or incomplete records of nursing care. Now that's another thing because nurses have a lot of work, then they are not writing it properly. So these are the probable risks that they identified. I'm only taking the nursing one. Then you validate the risk, particular risk, whether it's a now uh, you have to identify now this, once you identify this, what is the probability of having it? Probability. First, you have to identify probability. What is the chance of nurse making a mistake because of incompetencies or lack of nursing care? What is the chance of having problems, lack of ICU nurses? Uh, what is the chance of having, like, you get the probability first. Then you go to, okay, right, there's a chance of uh, 1 to 10. If 10 patients come, one patient can have this. That you can create that. Then you look at the consequence. Okay, it happened. If it happens, what's the consequence? What is the effect of that? So there are two things what we do. First, the probability and then the effect, right? Then you rate it, and then you can have different quantification and qualification. I'll show you another one. Then once you do that, you go to validation of the risk and then prioritization of the risk. I'll show you a small document. Now, validation is you put prioritize the effect, probability of the risk and the effect of the consequence of the risk, and you validate. If it's a severe risk, you have to must be managed by senior person. High risk, likewise, you just have a criterion how to address this particular this type of a risk. Who's going to address this, right? You scale the risk. I'm going to show you this. Now, if you look at the this nursing care, what we looked at, unable to deliver quality nursing care through incompetencies. Probability of having it very high. If you're not incompetent, you can make a mistake, no? Now, consequence, when they do mistakes, moderate because these incompetent nurses are not given extreme procedures, high risk procedures. They are given simple thing, making bed, taking temperature, TPR, that kind of a mild ones. Or probably giving an IM injection or IV you don't give. Likewise. So therefore, when you look at it, it's moderate. But when you look at validate the whole thing, it comes as a major thing because it's a major thing. Here it's a major risk. Senior management attention has to be needed because you have to have nursing care on a top form. Then lack of staff, probability is very high. With lack of staff, very high. Uh, but consequence is unlikely because existing staff, competent staff, they will try in some way or the other, they manage. But it is significant. So when it's significant, sorry, when it's significant, management responsibility must be specified. Likewise, there are. So when you look at the provide ICU nurses, very high probability. Consequently, unlikely, once again, the senior nurses will look after significant. Incorrect consumable, medium. Likewise, you can validate probability of the risk. First, identify the risk, have the probability, have the consequence, and then validate, which is a major, minor, severe, as I told you before. And it has to be, when you're trying to have a solution for this, you have to get these people, senior management, right? Detailed research has to be done, senior management attention, management responsibility. Likewise, when you try to find a solution, these are the things that you have to do. So then you come to a risk treatment. You try to treat the risk. You know how can you treat the risk? Risk treatment, or as another word is risk mitigation. Those are the two words that we use commonly. So to do risk treatment, identify the person responsible. So we got it from the list that I showed you. You have to have these risk, this prioritized risk. You have to answer these guys has to be there. Then you get together, put a team and do a root cause analysis. You know the root cause analysis, problem tree, and root cause analysis. You do that, and then root cause. Once you have identified the root causes, you can convert that root causes. You have to give a solution to the root causes. So your problem tree becomes a solution tree. So once you have the solutions, you can validate the solution. There are different methods of validating which solution is the ideal one. There are things called effect, cost, time analysis, ECT metrics. There are different ways of doing it. Or you just take your gut feel, your experience, you look at what's the best way of treating. But ECT metrics also another thing. Effect, cost, time. It's a simple. You put everything solutions here and look at how much of effect that you have with this to sort out this problem and the time that you take and the cost for that. So that's also another more scientific way of doing it. But nevertheless, you identify those particular risk areas, and then you look at once you have a solution, then you look at your guidelines given by the Ministry of Health, WHO, the British or whatever they have the solutions as well for these problems. And to go and then you write down your risk treatment method uh, based on the guideline. You have to adhere to guidelines also, no? Rather than you try to invent a wheel, if it's already there, you can use and adapt to your Maldivian conditions. Then organize a policy document. So put into all the policies and protocols this particular risk that you have, risk mitigation or the action plan that you created. And then you put it to a risk register. You have to have a risk register and then other documents. So I'm just showing you, I hope they can see. This is the medication error. So there are medication errors happening to the patient. So this is the dispensary. The root cause they have identified. Medication errors are due to careless in dispensing, right? Staff not checking the identity of the patient before giving the medication. Those we have found those root causes. Error in drug labels. So they put wrong labels in wrong drugs. So consequence is very high. Likelihood it unlikely. Chance of doing this is but likelihood it unlikely because they would somewhere or other catch these things happening. But risk level is significant. Now the risk treatment is that they convert this each one they have to reinforce all pharmacy staff the importance of taking extreme precaution in dispensing. So you have to train them, caution them. Dispensers are to check the name and MRN on prescription for this. Check the content label, initial label. You know who's responsible. Call patient name, verify all that. Nowadays, of course, you have the barcodes and etc. So that would prevent these things, but it's nice to do this as an exercise. And then error in drug labels, dispenser to check the MRN, check the content label, initial, excuse me, on the label. Call the patient name and verify you are giving it to the proper patient. Excuse me. So this is a responsible person and given you can put this and then of course the target date when you are going to do it. Then going with the treatment methodologies. Now this is another one. Let me see. Yeah. Just to give you a feel, this is nursing department here. Ensure the nursing staff are competent, including exposure to multi-dispensing disciplines of drug. The risk, possible causes, risk being, likewise, you can have the root causes are here, right? And then ensure the proper documentation done that I identified. Then consequence, moderate. You say consequence is very high, likelihood is moderate, risk levels major. So managed by nursing. Then we will have to have a mitigating strategy. Each one will have to um, we'll have to find a solution for all these root causes that you have found. Then finally, you do evaluation, monitor and communicate. You have to have a risk management committee. So they need to put into the job description. If they do well, so you get a performance appraisal regarding risk management. So the most of the custodian ownership of this particular master registers are the in charge basically. And then continuously you work with the audit department also. There has to be audit department, quality and risk management department. They would do the audits. So this audits also they should know what you have organized. So it's a collaborative effort that you do with the audit department, the clinical audit department, and then you agree on this on the risk mitigation strategies. This is kind of a risk register. So these are the in charge people, and then who are each department, who will have the risk manager, all that. This kind of a model you can create according to your hospital. Um, yeah, this is something similar. Yeah, then finally, if you go according to this implementation, very important to have the culture. If you don't have a culture, risk management, it get dissolved and disappeared. Because leadership has to have the leader of the unit will have to have the saying, create a nice culture, encourage everyone to report, transparency, no shame, no blame. You don't blame anyone, you don't shame anyone if you make a mistake. We are human beings and we are working in a difficult circumstances. You can make a mistake. So effective communication and teamwork, and then very important to have accountability. Who's accountable for what? Who's responsible for what? Role clarity is important. Otherwise, it's nobody's baby. You try to blame each other. That's very important to have a then continuous education and capacity building. You have a framework in National Safety Framework in Maldives. To 2021, it is launched by Minister of Health. Focus on patient, provider, entity systems. It's a beautiful document that you have. You can go through that and adapt that to your level. And start small, start simple, be positive, and then you can approach this. Um, Challenges and barriers in health, patient safety is resistant to change, right? We're very resistant to change. It's a common in healthcare professionals because we have been trained in such a way. They are very stubborn. We are very stubborn people. The training is such to look after patients, and it has gone somewhere wrong where we become very stubborn, not to open. We are closed people. So therefore, we'll have to create that nice culture and improve people to reduce the resistance to change, um, eliminate the fear, shame, and blame, as I told you before. Try your level best to push and get the staff, materials, funding, equipments, right? If they're inconsistent training, please make sure you train them properly. Have a nice mix of skills, um, and then create a nice conducive culture, not to have hierarchical way of doing things. Improve the communications amongst the staff, especially the younger ones, because they have to give them the confidence, create the confidence and training for them to inculcate in your system. If you resist initially, they will not support you. Then there's no teamwork. And weak incident reporting, tracking systems. It's very important to track every day, daily logs. If you go to countries like first world countries, Australia, UK, they see less patients, but they do a lot of documentation. That too much sometimes. UK and all that tracking systems, and then of course continuously uh, make your intervention sustainable. Some people start something, they stop, but it's our idea, our responsibility to making sure whatever you start continues. Uh, for your for nurses, of course, create a nice leadership controls uh, in your wards, and be proactive before it happens, and then and create the patient safety advocacy groups. They go and talk about it, make sure that everyone is aligning with that, As I told you before, documentation and reporting, use checklist, a lot of checklists. I know you all have been given by the Ministry of Health a lot protocols and double checks and all that. Sometimes that might go the wrong way because there are too many things also, because when you don't have time, when you are given a lot of documents also, then you will not do nothing. So therefore it's very important to have a balance of reporting, etc., whilst looking after the patient, and educate the patient also about safety. It's not only our responsibility. Patients also should be able to be careful in whatever that they do. They should support taking care of their own health or empower their health. And then, of course, standardization and teamwork. I think with this, if you need some questions, if you have questions, I can take up. I don't know what the procedure is. Nevertheless, I really appreciate giving this opportunity to talk to you. I think I have done few sessions on medical negligence before physically. This is after a while only. After years, I'm doing a webinar with you. Hope to do more in years to come. If you have any questions, I'll give it to uh, Ms. Apuara. She could coordinate. Thank you.